Hyperkalemia can kill your patient even after you treat it. Let me show you a real scenario. It's 2 a.m. in the ICU, you're monitoring the patients, everything is fine. You're just worried about one of your patients who is oliguric. A few minutes later, you notice that his T waves have peaked now, just what you feared. But lucky for him, you know how to manage hyperkalemia. You do, right? So the ABG report comes, it shows potassium of 7.2. The ECG shows tall peak T waves, and by now you also see PR interval has prolonged and P wave is starting to flatten. So you treat. You give calcium gluconate, you push insulin with glucose and high dose albuterol. And 30 minutes later the potassium falls to 5.2 and ECG changes have reverted, at least partially. Everyone relaxes. But 3 hours later, the monitor alarms again. The ECG now shows a sine wave pattern and the patient arrests. And you lose him. So, what went wrong? The potassium was improving, right? But the hyperkalemia was never actually treated. And by the end of this video, you'll understand exactly why this happened. See, this is why you don't just treat the number, you treat the patient. Let's examine what happened here. The potassium started at 7.2, treatment was given, and the potassium fell to 5.2. So the treatment worked, right? Not necessarily. Because many emergency treatments for hyperkalemia only shift potassium temporarily into cells. They do not remove any potassium from the body. So potassium can rebound hours later, and that's the mistake many clinicians make, treating the number but not the physiology. In this case, after it came down to 5.2, it again climbed back to 6.8. When managing hyperkalemia, always think in 4 steps. That way you'll never miss anything. Step 1. Protect the heart. Step 2. Shift potassium into cells. Step 3. Remove potassium from the body. And step 4. Figure out why it happened. If you remember this framework, hyperkalemia management becomes much simpler. So stabilize, move, remove, and only then figure out why. Hyperkalemia treatment happens in 2 phases. First, the immediate management that prevents cardiac death, and a definitive management which involves figuring out why it happened in the first place. If you miss any of these steps, the potassium can come back and kill the patient later anytime. We'll talk about the immediate management in this video and the evaluation in the next one. So let's start with protecting the heart. Hyperkalemia is dangerous because of its effects on the heart, and the ECG changes usually follow a progressive pattern. See, it is normal at a normal potassium level, and the first change to appear is tall peak T waves, which appear at a potassium of about 5.5 to 6.5. Then, PR gets prolonged, the P waves begin to flatten, and the QRS complex widens. This occurs at a potassium of 6.5 to 7.5. And eventually, all the waves merge to form a sine wave pattern. This appears at a potassium level of 8 or above. At this stage, cardiac arrest can occur at any moment. Now here's an important clinical pearl. The ECG does not correlate reliably with potassium levels. Some patients develop severe ECG changes at a potassium of only 6, while others may have a potassium above 7, 7.5 with minimal ECG changes. These patients usually have chronic kidney disease, hence are accustomed to high potassium levels. So never rely on the ECG alone. So step 1 in hyperkalemia management is to protect the heart. And that's where calcium comes in. But remember this, calcium does not lower potassium, it does not remove potassium from the body. What it does is stabilize the myocardial cell membrane. This effect begins within minutes but lasts only about 30 to 60 minutes. So repeat dosing may sometimes be necessary. And the usual dose is 10 ml of 10% calcium gluconate IV over 2 to 5 minutes. You can also use calcium chloride, but it usually requires a central line. And calcium gluconate can be given by peripheral line as well. Here's another important point. If you give calcium and stop there, the potassium problem is still present. That's why calcium must always be followed by potassium lowering therapy. Now to understand the next step, you need to remember one key concept. You see, about 40% of body weight is constituted by the water present inside the cells, whereas serum contains water roughly about only 5% of body weight. So you can imagine the difference between these two pools. When we check for potassium levels, we're checking in the smaller pool, simply unaware of what's happening in the bigger pool. Also, the cells have even more potassium concentration wise, whereas serum does not. For comparison, serum has a potassium level of around 4, that is 3.5 to 4.5, and cells have it at around 140. So a large volume and a large concentration in that given volume, which means that over 98% of total body potassium is inside the cells, and only 2% is outside. So imagine the difference in total quantity and concentration gradient that exists. Now this huge concentration gradient requires a lot of energy. These are maintained by the sodium-potassium pump. These pumps are present on most cells, and they work constantly, consuming roughly 1/3 of your basal metabolic rate to keep potassium inside and sodium outside. So what do you think happens when even a tiny amount of potassium leaks from a large number of cells? Exactly, it can cause a dramatic rise of serum potassium. Now look at it in reverse.
What this means is there's a huge reservoir inside the cells where we can dump the extra potassium from the serum, which essentially brings us to step 2, that is, shift potassium back into cells. Now these pumps can be stimulated and made to work more by insulin, beta agonists and thyroid hormones, and they are inhibited by beta blockers and low pH, that is acidotic milieu, which explains why acidosis, be it of any cause, usually has accompanying hyperkalemia. That's because the pump doesn't function properly and potassium leaks out. And so there are 3 main therapies: first insulin, second beta 2 agonists, and third correction of acidosis. Now insulin is the most reliable therapy. It stimulates the sodium potassium ATPase pump and drives potassium into cells. The usual dose is 10 units of regular insulin IV given with 25 grams of glucose to prevent hypoglycemia. Onset of action is about 15 to 30 minutes, and amongst all potassium shifting therapies, insulin is the most predictable and reliable. And beta agonists may fail in up to 40% of patients, but insulin almost always works. Apart from these, sodium bicarbonate can be used, but only when acidosis is contributory. Now we come to the most important step, actually removing potassium from the body. We did not do this in our patient, and hence potassium came back to stop his heart. Now because everything we've discussed so far only temporarily shifts potassium, so if potassium is not removed, it can rebound later. So understand this first. Potassium comes from your diet, enters the bloodstream, is given to all the cells to keep, and if it is still in excess, the kidneys excrete them. About 5% is excreted by the intestines too. Now to remove potassium, our options include either we can stop its entry from the gut, potassium binders like polystyrene sulfonate, patiromer, or sodium zirconium cyclosilicate. On the other hand, we can maximize its excretion by the kidneys. We can use diuretics if kidney functions allow it. This will maximize the urine output and also the potassium excretion along with it. And when kidneys aren't functioning and everything else fails, in those cases, hemodialysis. See, dialysis is required when hyperkalemia is severe or refractory, in advanced kidney failure, or in ongoing potassium release like rhabdomyolysis or tumor lysis syndrome, or when there are life-threatening ECG changes. In these situations, dialysis is the fastest and most definitive way to remove potassium. Now let's go back to our ICU patient. The potassium fell from 7.2 to 5.2, but potassium was never removed from the body, so it rebounded, and the patient developed a fatal arrhythmia. So, final recap, whenever you see hyperkalemia, remember 4 steps. Protect the heart, shift potassium into cells, remove potassium from the body, and finally, find the cause. Now that you know how to treat hyperkalemia, the next question is, why did it happen in the first place? In the next video, we'll break down the most important causes every resident and medical student must recognize. If you have any suggestions or any queries, drop them down in the comments below. Like, share and subscribe. See you in the next video.